So without further ado, I just would like to introduce our presenter, Wendy Bassett. Wendy Bassett is a clinical social worker and psychotherapist with extensive experience working with a variety of populations who have experienced trauma. She's a cognitive processing therapy for PTSD trainer and consultant. She's also currently an assistant clinical professor of psychiatry at Yale School of Medicine and an adjunct lecturer at NYU Silver School of Social Work. Thank you so much, Wendy, for joining us today.
Thank you so much for having me, and I'm so glad we have so many people today who are interested in learning more about cognitive processing therapy for PTSD. So before I dive into what our agenda would be, I'm very curious if any of you happen to catch one of the latest This American Life episodes. There was an episode aired called 10 Sessions. It was aired on August 23rd, and it was all about CPT, or cognitive processing therapy. So if you did happen to see that, please chat in, all panelists, just so I can have a sense on if people actually got to hear the therapy in action. And if you didn't get a chance to, I highly recommend it. It's a great depiction of psychotherapy in general in the media, which as a psychotherapist, I'm always pleased to see, but also a really lovely illustration of CPT and how well it works. So what I'm going to do today is give you a very brief overview of CPT. When we train folks officially in CPT, it's usually a 2-day in-person workshop. So I'm consolidating some of the essentials into about a 50-minute bite size for you today. So what I'm going to do is briefly touch on the DSM-5 diagnostic criteria for post-traumatic stress disorders and different evidence-based psychotherapies for PTSD. And then I'm going to talk more about what is CPT, some of the empirical support that supports its use, the theories that underlie it, and then give you a quick overview of what the sessions are. The video, you can see the video. There's a link at the back of my slide deck here, but you can go to This American Life, and it's called 10 Sessions for those of you who didn't catch it yet. I'm going to talk a little bit about the clinical relationship in CPT. I know definitely in social work fields, right, we talk a lot about the importance of our clinical relationship, and so help folks think about how we consider that in cognitive processing therapy in a manualized protocol. And I'm going to give you 3 case examples so you can see how well the intervention can work. And then Lydia and I can talk a little bit more about different resources for CPT, including if you want to pursue further training and further reading, and then we can have a Q&A and talk about the CEs. So DSM-5 2013 changed some things about PTSD that's important to highlight, and I'm assuming most of you are familiar with the diagnostic criteria, but there are some important changes. But also because CPT is a treatment for post-traumatic stress disorder specifically, it's always important to start with what is PTSD. Lots of people, lots of seasoned clinicians, and even the This American Life episode didn't clearly say that it was for PTSD. It was more that it was a treatment for trauma. But trauma doesn't always result in PTSD, right? So CPT is specifically for PTSD and our clients with PTSD. Certainly it can be helpful with subthreshold PTSD or a trauma stressor-related disorder, but it needs to be PTSD. So the first criterion is A, and that is really the definition of a trauma. And so in PTSD, a trauma for criterion A is an actual or threatened death or serious injury event, or an event of sexual violence and violation. It can directly happen to a person. A person could witness it happening to somebody else, or what's new to DSM-5 is someone could learn of it happening to a loved one and not have been there and still meet criterion A. That's new, right? So we did some work after the Sandy Hook massacre in Connecticut where we trained some community clinicians in CPT, and there definitely were parents whose children survived and the parents were not in the school, and they met criteria for PTSD. Criterion A also includes folks who might have repeated exposure to details of trauma, like a homicide detective or an attorney who's doing human rights work at the border, or people in our profession. So that's an important addition. So I'm going to walk through the different clusters, and I'm going to do it in a little bit different order just because it helps us understand how CPT works to treat this particular disorder. So 4 clusters of symptoms. Cluster B is intrusions. It used to be called re-experiencing. But what that cluster is about is that the trauma event or events come back in intense, vivid, and unwanted ways when the person is asleep or awake. Sometimes it can show up in dreams and nightmares that are composites, and it's hard to tell what exactly it's related to, but it's thematically similar. Sometimes it's exact replaying of the event when awake or asleep. It can be a flash. It could be an experience that takes many minutes, a flashback, where it's in a dissociative experience where someone kind of gets lost in the memory and loses touch with where they are in the present. And intrusive symptoms is also when people are cued. Oh, I apologize, I have a New York emergency response in my background here. It can also happen when people are reminded, sensory cues, sight, sound, smells, people, places, things, that might cue an intense physiological or emotional response. So sometimes people might not have other intrusions, but have a lot of this cued reactivity. You only need to have one in that cluster to meet the criterion of that cluster. So I'm going to skip over C and come back to it in a minute. Criterion D is sort of a reorganization of other clusters from DSM-4, and it has a new name. It's called negative alterations in thoughts and feelings, or cognitions and mood. And what is included in this cluster is amnesia, right? Sometimes trauma survivors are missing moments of the trauma before or after, not secondary to intoxication or loss of consciousness. But this also includes 2 new symptoms that weren't in DSM-4, and one of them is overgeneralized negative beliefs about oneself, others, and the world. And you will probably recognize these when I say them. No one can be trusted. I'm damaged goods. I have to always be in control to stay safe. The world's dangerous. If anyone knew what happened to me, they would leave me. So these very extreme, overgeneralized, and painful thoughts. The other kinds of thoughts that are now symptoms are persistent and distorted thoughts about why the trauma happened. And I'll come to this when I'm talking more about how we intervene in CPT. Thoughts that can take the shape of, there must be a reason this happened. It's my fault. Or other blame, like it's my mother's fault. My grandfather abused me, right? Where the sort of the wrong person gets attributed fully to the assault, right? And maybe the mother colluded or played a role, but the grandfather kind of gets off the hook in that example. So these 2 new symptoms that have to do with cognition. And for those of us who understand cognitive behavioral therapy, where how we think influences how we feel, of course those kinds of thinking are going to generate profound negative emotional states and keep people feeling hard to access positive emotions. I've had people say, I feel like I'm a stone, or I'm like a ghost living my life, or living my life through plexiglass, feeling detached from people, from oneself. So this is a very important cluster, and it ends up being one of the clusters that we directly intervene with CPT. So moving on to criterion E, which is arousal or hyperarousal, has to do with the body. So if we think about the trauma survivors has intense, vivid reminders intruding and memories intruding on their lives. They're having all sorts of negative thinking and intense negative feelings and feeling disconnected from self and others. And then their bodies are keyed up and on edge, waiting for the axe to fall. Hypervigilant, startling easily, poor sleep and concentration, reckless self-destructive behavior, that's a new symptom in this group, and irritability and anger problems, like a guitar string tightens so tight that one little pluck snaps it. So you only have to have 2 symptoms in cluster D and 2 in E. So the reason why I put avoidance last is because this is how we think about it in CPT, is that avoidance comes at the end. So if you can imagine, put yourself in a person with PTSD's shoes, having all these other clusters can get somebody very dysregulated, very much in pain. And so what do humans do when we hurt? We retreat, right? And so understandable why people avoid when they have PTSD. They're trying to push it down. People with PTSD become masterful at avoiding and trying to shut down. I think of it like a seesaw on a playground, though. The more you push it down, the more it comes up. It finds ways to come up. So that's how so I'll talk more about how we'll intervene specifically. So of course, there's a different organization and a little bit different description of symptoms for kids 6 and under. There's a dissociative subtype. There's delayed expression. If you have it a month, it's called acute stress disorder. It becomes PTSD after a month, and chronic PTSD after 3 months. So what's important is that not everybody gets PTSD after a trauma, that in fact, most trauma survivors have what we call a natural recovery, which means they can use their internal resiliency or their social supports or their faith to help themselves recover. But some people, of course, do get PTSD. So the DSM-5 reports that about 80% of Americans experience a trauma in their lifetimes. Men more likely to be exposed to that than women. Men, about a 4% rate of PTSD lifetime occurrence, and women about 10%. There's some, as a side note, there's some fascinating research going on at the National Center for PTSD in Boston, the Women's Health Sciences Division, looking at female sex hormones and why that might make women more vulnerable to developing the disorder. It's really interesting. We also know that when people do develop PTSD, and there are people who've dedicated their entire careers to studying this, that people do, in fact, and can recover. When I first started working at the VA, was a social work intern in 2002, we really thought that PTSD was like a life sentence, that our Vietnam vets, and this is sort of what they were told when they came back, is that it was something they were going to have forever. But now we know that, in fact, PTSD is quite treatable. People do not have to bear the symptoms for an entire life, that they can and do recover. So Dr. Patricia Rizek, who's one of my mentors and the developer of CPT, conceptualized it through her epidemiology research and looking at studying PTSD and what happens specifically after rape, is that conceptualized PTSD as a stalled recovery, not a psychopathology that develops, but rather when something blocks somebody, something gets in the way of their own natural recovery process. The idea is that we all have internal capacity to recover. Some of us need more of a boost than others. And trauma-focused treatments, like cognitive processing therapy, are designed to get the person unstuck. And it is important to note that recovery does not mean, as one veteran I worked with once said, turning the trauma into rainbows and unicorns, right? Of course. It is not erasing or making an event nice. We are realists in CPT, right? We're trying to help our clients face it as it happens in all of its awfulness and think and feel to the other side, which can result in significantly reducing and maybe even eliminating the symptoms. So the VA and the Department of Defense collaboratively come up with best practice guidelines. So these are for adults because that's primarily who we're treating in VA and DOD settings. Of course, trauma-focused cognitive behavioral therapy, or TFCBT, is one of the best practices for children. And so here are the 7 trauma-focused psychotherapies that are recommended as first-line treatments. Anyone trained in any of these, if you would chat all, let me see what other modalities people are trained in, including TFCBT, just so I have a sense of who we have on our call. All right, so it used to be that it was just CPT and prolonged exposure, or PE, and EMDR, but what I think is really exciting is more research is being done, and the evidence is building that our choices for how to help our clients with PTSD are expanding, right? It's not only one therapy that works. There's enough variety that allows a therapist to be drawn to the kind of therapy that appeals to them and for clients to have choice, right? Narrative therapy, okay, trained in EMDR, great. So it's also interesting is that these psychotherapies are recommended as first-line treatments over standalone psychopharm, right? So of course we might combine psychopharm with psychotherapy, but that it's not in the VA, DOD, we wouldn't start somebody off with meds first. We'd start with trying to also offer psychotherapy. All right, so what is CPT? So it is a cognitive behavioral therapy for PTSD developed by Dr. Rizik in 1980s, initially to work with rape survivors. To this date, there are 23 published randomized controlled trials that show its effectiveness in helping reduce PTSD symptoms related to childhood physical and sexual abuse, rape and sexual assault, both in the military and civilian populations, and natural disasters. I've seen it work with cases also with suicide of a loved one, violent accidents, motor vehicle accidents, burglaries, many, many types of traumas. And it is also on first-line treatment guidelines with the International Society for Traumatic Stress Studies. One of the things I love about CPT is that it is flexible in how we can deliver it. So while it is a manualized protocol and different than TF-CBT, we don't offer it in modules. We offer it session 1, 2, 3 in order, and really working not to add sessions. So it is structured and agenda-driven. It was initially designed as a 12-session weekly therapy, and that's the standard offering. But some recent research head by my colleague Tara Golofsky and colleagues, we've learned that some people can be done as early as 7 sessions, and some people might need a few more sessions like 18. So there's flexibility in that. Can also be offered 1 time a week or 2 times a week. That's where most of the evidence base is to support its use. For those of you who heard the This American Life episode, that journalist and client did it once a day, 5 days for 2 weeks in a row, and a total of 10 sessions. So that's a very intensive dose, and some of those more intensive doses are currently being studied. It can be offered in a group format. I love doing CPT in group, or individual, or it can be offered in a combined format where you do both group and individual, all 12 sessions, or you offer individual to enhance some trauma processing while doing most of it in the group. And for those of you trained in PE or TF-CBT, CPT now can be done with or without the trauma narrative. So in fact, the treatment developers recoined the way we describe the 2 different versions of the therapy. CPT is the new main modality, is the version without the trauma narrative. We still do trauma processing, but we do it through Socratic dialogue. We do it through working on distorted cognitions, and CPT plus A is the version with the trauma narrative. So it is, and that was a big surprise. That was even, I've heard Patty Rizik talk about that, saying she herself was very surprised that we might not need that trauma narrative. But our research and my clinical experience has showed that we really don't need that. All right, so just to review some of these RCTs, these are all available, the articles are all available on the CPT for PTSD website. That link is also at the back of the deck. But just want to give you a sense of what my CPT colleagues have been studying. So the trauma types over there on the left, military sexual trauma, combat, physical assault, rape, childhood sexual abuse, all of those studies included people with comorbidities, such as borderline personality disorder. They also, the people in those studies had many, many traumas. The sexual abuse sample, adult females, survivors of sexual trauma, 80% of that sample had more than 100 instances of penetration, so a highly traumatized population. It's been studied with civilians, with active duty military, veterans, male, female, and more recently, an exciting study about adolescents. It's been studied in the US, Australia, Germany, and the Democratic Republic of Congo. And that population were women who were in a war-torn country who were illiterate, and so they had to adapt CPT to be delivered to them. Different modalities about CPT have been studied, individual, group, combined. It's been studied telemental health only, so over video, secure video conference versus in person, found to be effective. And then it's been added or different adaptations. That DCPT stands for developmentally adapted CPT. And it's been compared to a lot of different treatments, delayed treatment, treatment as usual, some other trauma-focused interventions and modalities from CPT. So this is a slide just to give you, this is from our CPT trainer slide deck, a bar graph of the different RCTs. The clinician-administered PTSD scale is considered the gold standard assessment for PTSD, and that is on the y-axis. So the more extreme, the higher the score, the more extreme the symptoms. The cutoff is 45, and along the bottom of the x-axis are some of these studies. So pre is the teal, and that sort of goldy beige is the post. These are average scores of the participants in the studies, and they're an intent to treat sample, which means that even if people came to one session of CPT and dropped out of the study, we still counted, my colleagues still counted their scores in here. So the ones that are the higher, so that they're above, hovering around 45 or higher, really interesting about those are all the veteran and military samples. Even the Forbes one right in the middle, hovering just under 50. The other ones are community samples. And this has been my experience in clinically and also in doing case consultation with clinicians whom I'm training in CPT, is that civilians respond much more robustly. Veterans a little trickier, and active duty a little harder. They still get better, right? We still see a change between the teal and the gold bar, but our civilian populations tend to respond more robustly. All the way over, well, let me start the second from the left. That's Dr. Shard's study. That's the adult female childhood sexual abuse survivors. They did really well in the study on average. And the Rosner et al., all the way over on the right, that 2019 study, that's the most recent adolescent study. That paper just came out. Those adolescents responded really well on average too. Here's a slide about BDI, Best Depression Inventory. So what's so interesting, right? CPT is a treatment for post-traumatic stress disorder. This is pre is teal, post is the gold, and the higher the score on the y-axis is the BDI, 14 is the cutoff. So you can see people started CPT with a lot of depressive symptoms, and CPT, even though it doesn't directly target depression, it really can be effective in decreasing those symptoms as well. So this Rosner et al. Study looked with a randomized controlled trial in Germany comparing what's called developmental CPT versus waitlist condition. And they looked at a population of 14 through 22-year-olds. Oh yes, I'm seeing someone say a list of all my acronyms, and I'm sorry, I could have spelled those out. I think because I worked in the VA for so long, I'm just sort of used to slinging those around. So DCPT stands for Developmental Cognitive Processing Therapy, which was a developmental adaptation, which I'll explain what that means. And WL stands for waitlist right here. So there was a study, was 88 14 to 22-year-olds, and their traumas were from childhood sexual and physical abuse. So what the treatment looked like was a motivational component first, because they were worried these adolescents would drop out. They did an affect regulation module first, second, and then they did CPT at an intense dose, sometimes 3 times a week. And they paid special attention to adolescent developmental tasks such as focusing on school-career relationships. They found that this developmental adaptation with CPT did better than waitlist, that the DCPT had the best results. And they thought, when they sort of broke down these different components, and they really questioned whether there really needed to even be these pre-CPT interventions. So that's really exciting. And that's what I've seen in my case consultation practice, people trying this with adolescents, and of course being attuned to developmental tasks and other developmental concerns, but not necessarily always needing pre-CPT interventions, right? Sometimes we do, sometimes we don't. And even more interesting to me is that the younger adolescents seem to have better adults than the 18-plus group. And Rosner and colleagues suggest that by getting at PTSD early in a person's life, it might help the borderline symptoms that sometimes we see with PTSD, that dysregulation, might prevent that from becoming chronic. I think that's a really interesting and exciting finding. All right, so someone had typed in a few minutes earlier to ask about race and ethnicity. So just in terms of sex, men and women have similar treatment outcomes. There aren't any studies that look at transgendered folks yet. As race, as far as we know, no difference in treatment outcomes. There's been one study that suggested African-American women might be more likely to drop out than white women, but another study found that it didn't. And I haven't come through that study. My first question, which maybe some of you would have, is I don't know what was it a cross-cultural therapist-client dyad? That would be really interesting to know in those dropouts. In terms of military era, our OEF, OIF vets, Iraq and Afghanistan vets have larger treatment gains, but they're more likely to drop out than Vietnam vets, but our Vietnam era folks still get better. Borderline personality disorder, we don't have to, it's not a contraindication, and in fact, that doesn't predict CPT outcome. We're learning more and more that we can treat substance use disorders and PTSD simultaneously. There's no different in outcome there. And CPT can work really well with folks with a TBI, traumatic brain injury, and we can offer accommodations and adaptations if folks have cognitive deficits that might warrant that. So it seems like some folks have typed in here that they're familiar with CBT. Well, let me just, I'll give a general. So cognitive behavioral therapy. So CPT is a cognitive behavioral therapy. And so its very first principle has to do with how we think about what we've been through in our lives can influence how we feel. And that drives how we behave, right? So in a CBT intervention, we can intervene in behavior, we can help people articulate and identify feelings, and we can teach people skills to intervene in thinking, right? And of course, behavior and how the world responds to us might reinforce thinking, which then drives feelings. So CPT is a CBT intervention. We care a lot about thoughts and feelings, and we spend a lot of time helping our clients identify thoughts and feelings and skills to work with thoughts and feelings. CPT also uses what's called the social cognitive theory of PTSD. And the basic gist of this is that to make sense of our world, human beings are meaning makers. We make sense. We ask why. We take our life experiences and we sort them into categories to try to feel a sense of control, to feel a sense of connection and meaning. We do it with language, right? We do it even when we're pre-verbal. We're still starting to sort and make sense of. So these are schemas, the schemas that drive us, that we might be aware of or we might not be aware of. When a trauma happens, it intersects with the trauma survivor's schema or schemas. And when people cannot wrap their head around why it happened, because the trauma clashes, say, with a prior schema, say someone grew up and did really well in high school, was on the student government council, felt very confident and competent, and then later ends up getting in a motor vehicle accident and felt so out of control and incompetent, right? Then that clashes with their prior view of themselves as being able to handle it. Or someone, say, who grew up in a violent home where it was chaotic and there was alcoholism, and then goes to college and gets raped. That rape might reinforce a sense of powerlessness and dangerousness that they experienced from childhood. So in CPT, we want to understand what happened to our clients' schemas and how did the trauma interact with them. So that PTSD occurs when a natural recovery stalls out, and this happens primarily when the survivor can't make sense. They reach back to a prior schema that just can't fully make sense. And this results in the painful symptoms that are PTSD. So there are 4 specific ways we think about what gets somebody stuck. And two of them are called stuck points. But the primary way, as I said earlier, has to do with avoidance. Avoidance. People avoid, they don't want to face it because it hurts so much. But that keeps them from giving themselves the opportunity to think and feel to the other side of the trauma, to process the memory. So the memory and the feelings can stay as intense 4 decades later as they were a day in 1970, right? The other way people get stuck, and in CPT we call cognitive distortion stuck points, so we don't use terms like core beliefs or automatic thoughts just because it's the cognitions that keep people stuck from recovering, but it is those ideas. The first is trauma misappraisals, so attributing the trauma to something that didn't necessarily cause it, right? Commonly, sexual trauma survivors might attribute what they wore or attribute a decision they made, right? Say it was a car accident. Someone might attribute, oh, I should have left 5 minutes earlier. And these often have blame content and undoing, where somebody is trying to rewind time and play it out differently. If only, I shoulda, coulda, it's my fault. That's the content of those kind of stuck points. The other kind of stuck point has to do with extreme conclusions about self, others, in the world after trauma, those generalized ideas that I talked about that are in that criterion D of the disorder. No one can be trusted. I will always be hurt. I'm damaged goods. If I go out on a date, I will be raped again. Those kinds of very extreme thoughts. And in line with our CBT theory, how people think and these stuck points generate very painful negative feelings we call manufactured emotions in CPT, and those get in the way of people feeling and processing what CPT considers natural emotions. I say to my clients, good news, bad news about natural emotions when it comes to a trauma. The bad news is they're not the fun ones, right? When you've been through a trauma, they're not the fun feelings. They're often sadness, anger if you've been hurt on purpose, fear, disgust. But the good news is if you let yourself access them, those natural feelings can move rather quickly. They can dissipate. So our goal in CPT is to help people get unstuck and to integrate the trauma, to expand, help them expand their schema so they can kind of hold the trauma and accept it while feeling those natural feelings. So we do this through multiple phases. First is a phase about education, teaching the cognitive model. We have a phase of trauma processing where we help our clients face the trauma directly versus avoid, and to tolerate and allowing those natural emotions to ease. And we help them identify and work on stuck points. By blocking avoidance, we help clients achieve more balance and help them accept the event happen as they did. So it's recommended for adults or adolescents. That new data shows as young as 14. And for folks who have PTSD as a primary disorder, but there can be other comorbid diagnoses, right? So PTSD has got to be driving their distress. If someone's in a current psychotic or active mania, that mental illness is driving their distress, PTSD might be secondary. But if someone's stable in those other disorders, you might see the PTSD more clearly, then CPT could definitely be indicated. So I'm going to go through the different phases. So phase 1 is pre-treatment. So we need to assess for PTSD formally, lots of different ways to do that. We want to describe the therapy to someone in depth and how it might be different. We can employ motivational tools, such as motivational interviewing, to help them put into words why it might be a good choice for them now to face this versus us pulling them along. Informed consent is a really important part, so they know that there's practice assignments, that it's structured, that the therapist is active, that it's agenda-driven, that they might get a little worse before they get better. Not everyone does. Sometimes people get better pretty quickly. And for folks who are multi-traumatized, we might want to spend a little bit of time trying to narrow down what we call the index event, or the event that's most driving the PTSD symptoms. Phase 2 is when we actually start the protocol. So I want to just say something about phase 1. Sometimes it's 5 minutes. If somebody comes to me really well screened from a colleague who's diagnosed them and talked to them about CPT, maybe I just meet them one session, or maybe we even get started that session. But I've also had a client who I treated for 6 years before she was motivated to start CPT, right? So sometimes it's 5 minutes, sometimes it's 6 years. So once we get started in sessions 1, 2, and 3, it's really about providing psychoeducation for our clients about PTSD, helping them figure out what the PTSD symptoms are, the clinician getting more familiar, but then helping them start to identify the thoughts that are interfering in their recovery and labeling emotions. We help them begin to identify stuck points, those distorted thoughts about the trauma and all of life, and we introduce a 3-column thought record, a pretty standard 3-column thought record that we call the ABC sheet. So for practice assignments at session 1, we send them home to write an impact statement where they write about how the trauma affected them. It's not a trauma narrative, it's more ends up being a stuck point finder and a way where they talk about their symptoms, right, how lonely they are. It becomes their words about why it's time to face the trauma. And we use that impact statement to find stuck points. We send them home with a stuck point log where together we start to list them, becomes our list of what we're going to target during the therapy, and we assign daily work with practice, with thought identification, feeling identification with the ABC sheet. At session 3 is when we start to turn more to the trauma, and we, at session 3, start to do some of those trauma-related stuck points in session and send them home to do those for practice. Phase 3, sort of right in before the middle part of the 12-session version of the therapy, is when we do the trauma processing. And we can do that, well, let me say first why. We challenge their stuck points about self-blame. I should have this, I should have that. It's my fault because, it's his fault because, if only I had, it would have not had the trauma happen. We focus on those thoughts using worksheets, using Socratic dialogue, and our goal is, of course, to help our clients access those natural feelings. CPT-A could offer the optional written trauma narrative to help with this, but as I said earlier, we don't need it, and it can really be client choice. We advance the cognitive challenging skills with different worksheets, moving towards a 7-column. We break them out in the challenging questions worksheets. Session 5, we introduce a worksheet we call patterns of problematic thinking, which are pretty standard, overgeneralizing, all or none, those kinds of patterns. And we break them down so our clients can try them before we pull it all together in sessions 6 and 7. So in phase 4, learning to challenge is when we really turn over the challenging to our client. In the beginning, the therapist is more active in modeling, but then we move more towards coach with the client taking on more of the role. They've got the skills now. We pull it all together on the CBW, and we continue to focus on those self-blame and undoing thoughts if needed. And we can also, at session 7, introduce our trauma themes. So those themes are safety, trust, power, control, esteem, and intimacy. And we spend one session focusing on a theme. And people are often have some things that resonate more than others, and that's okay. Sometimes people want them all. But we're really helping our clients look at prior beliefs before the trauma, what the trauma did to beliefs, what beliefs are now, and we're helping clients examine thoughts to move towards more balanced statement. And so we assign the CBW, which is the 7-column worksheet, and have folks keep doing daily practice. We have a couple of other assignments at session 11, a behavioral activation assignment, and at session 12, we assign a final impact statement. So at session 12, we're really trying to help our client review, celebrate what worked, reinforce what worked, and start to identify what goals are next for treatment or in their lives to continue to work on. And as a reminder, some people are done as early as 7, and some might need a few more sessions to get to what we think of as a good end state. So, of course, the clinical relationship is important, right? Otherwise, it wouldn't be good therapy. That we need to be, even when we're doing a protocol or manualized treatment, of course, we want to be warm and empathic. We want to be gracious and gentle. And in CPT, we need to be direct. We need to point out and help identify avoidance when we see it, given how prominent it is with the disorder. But one of the ways we do that is with informed consent as an essential and continual process. So it isn't just a document someone signs before they get going, although sometimes we might do that, but it's rather asking for their consent to work on a certain stuck point or to shift gears to work on a trauma-related thought, and using a collaborative relationship, shared decision-making about what to focus on to be of best service to help them with their PTSD symptoms. So we need to continually be motivating, getting their buy-in, and working collaboratively as a team. Candace Munson, one of the treatment developers, says detectives together, right? We're a team, detectives together, working to get the client unstuck from the PTSD. And we model compassionate examination of the facts and acceptance of the emotions and teach our client to be their own therapist. So I've disguised some cases for you, but I just want you to get a sense of how the model can work. So case number 1, 30 of Hispanic single female in 30s with major depression and PTSD with 2 young children, had a bunch of traumas, did CPT in twice a week setting. And the index event, so the event that was driving her PTSD was that she was raped at the end of one of the pregnancies. This PCL is the post-traumatic stress disorder checklist. The higher the score, goes as high as 80, the more symptomatic, and the cutoff is 31. Look at what happened. She had a steady decrease all the way to 12, well below cutoff by the time she ended the protocol. And some of the stuck points addressed, it's my fault, my daughter has behavioral problems, the rape caused my daughter's problems, and then tons of self-blame. I should have told him no, I should have handled the packages myself, should have gone to families instead of the store, and it's my fault because I asked for help. And that was the focus of the treatment, plus other more generalized thoughts, but I wanted you to get a sense of how those trauma-related thoughts can show up. And those resolved, mostly resolved. Hers were still a little stuck at the end, but that score went really low. Here's a teen, 16-year-old Caucasian female, sexually abused by a family friend, and history of a suicide attempt, and did CPT in an outpatient setting. So 57 as a start is well over threshold, and look what happens by the time she gets to mid-treatment, right? That score just starts to take a dive. By session 2, as soon as she starts to conceptualize that she wasn't to blame, that PCL score started to go down. There was a lot of blame about the parents, right, which is so fascinating, right? The person who actually did the abuse is totally not in any of the stuck points, right? And this isn't to say that the parents didn't have responsibility to protect the daughter, but she was very focused on them being the reason it happened rather than the person who actually did the act of abuse. Okay, One more case here, late 20s African-American married female with PTSD and alcohol use disorder, 2 times a week in an outpatient setting. So this was a case where the trauma was she witnessed a sibling being sexually abused by an adult when they were children, started out at 39, and by session 6 she was an 8, and she ended as an early response at session 9 with a PCL in the single digits, right? A lot about what she should have done, and a lot of self-blame that got resolved and got resolved rapidly. All right, so I think I'm done. So Lydia's going to take it back, and then we're going to turn to a Q&A.
Great. We do have some folks that have asked about some of the training options. And since you have this slide up, do you want to kind of walk through some options and how to access materials and things like that related to CPT?
Yes. Yes. Great. So our standard training in CPT is a 2 or 3 day workshop. The 3rd day is a group day, so learning to deliver it in group modality. That's led by an approved CPT trainer. There then is an option for case consultation, weekly case consultation afterwards. We typically offer 20 calls weekly to help folks deliver the treatment in their practice settings and troubleshoot all of the really interesting clinical things that happen when we try to do psychotherapy. When folks complete the training requirements, they can be rostered on the CPT provider list. All of that information can be accessed on the cptforptsd.com link. That is the treatment developers, Dr. Patty Rezick, Dr. Candace Munson, and Dr. Kate Shar's website. You could look for trainings that are near you, or you could consider inviting a trainer to come to your agency or agencies. But I know for those of you who are well upstate New York, I've recently done 2 trainings up, one in Watertown and one in Alexandria Bay, and I know Dr. Rezick was in Buffalo several years ago, did a big CPT training project through the University of Buffalo School for Social Work. So there have been CPT trainings up in upstate recently. But upcoming, very excited to say we have a training at NYU Silver School for Social Work. That's an intensive CPT training initiative that's grant funded by the Gavin Farrell Foundation. And this is a workshop plus learning collaborative model. So there's the in-person workshop components, and those dates are below. And then there is learning collaborative as a part of it. And that is weekly case consultation for those 20 weeks. So therefore, folks who can commit to the whole package. And what we're looking for in that group is folks who are working in agency settings. The funder really wants to help decrease barriers for low-income communities, for folks with PTSD who don't have access to EBPs to do that. So if you think you might qualify, your agency might qualify, or you just want to learn more, there's a link to that training initiatives page.
Great. Thank you so much, Wendy. And so I should just point out that these are training opportunities outside of CTAC. So they're either through, as you see, the CPT for PTSD, lots of acronyms, .com through the developers, or as Wendy mentioned, that there's this new opportunity coming out of the NYU CPT training initiative as well that's currently happening, if you're interested. So feel free to reach folks directly, as well as Wendy, who could probably answer your questions around additional training opportunities. I did want to show, so yes, please, we do have some minutes for questions, so please go ahead and start submitting some of your questions. I did want to highlight, and Wendy, I know folks wanted this American Life link, and I did try to submit it through the chat box, but just in case it's also here, you could probably Google This American Life, and it'll pop up, and as Wendy mentioned, it's the 10 Sessions episode. Is there any other one here you'd like to highlight? Obviously, CPT for PTSD is a great resource, goes in deeper around all the research that Wendy went through and additional information.
Yeah, so there's also a free online training through the Medical University of South Carolina. So it doesn't replace, we got back one. It doesn't replace, it doesn't replace an in-person workshop, but it's a great way to get more familiarized with it. I believe it's about 6 hours or 8 hours to complete. It's free. So if folks want to learn a little bit more about it, to see if they're interested in doing an in-person workshop and getting case consultation, that's a way to familiarize yourself more in depth than what I offered today.
Great. Okay, so we have a couple questions. So there's one that just came in wondering about utilizing CPT in inpatient rehab for addiction settings, if they're interested in trying to do it in a 28-day rehab program. Have you had any experience with that or know of others who have utilized it in that setting?
I do. And in fact, I've been working with an inpatient substance abuse agency organization to help them do just that. And so yeah, I meant to mention this earlier, is so there are places where people are trying to do it in inpatient settings and addiction treatment settings, and what it means is doing it 3 times a week. And that can be a lot for some folks in early recovery. So it really has to do with that shared decision-making and collaboration with the client and the treatment team, as if PTSD is really driving the addiction, that you really think you need to get at both disorders simultaneously, and the client is motivated. I've been seeing it work amazingly well. When a team of clinicians, when their CBT model for addiction works well with cognitive processing therapy, they've had like single-digit people ending with PCLs in the single digits. It's really promising. So there hasn't been a randomized controlled trial at that dose, and we don't have follow-up studies, so how well those folks hold, but it's really, really promising. I wish this group I've been working with would publish an effectiveness study, because I think it's really exciting.
Great, thank you. We also have a question around how different CPT is from CBT.
CBT?
Yeah, cognitive behavioral therapy versus cognitive processing therapy.
So it is CBT at its heart. It is that. So those of you who are trained in CBT, you're going to recognize it, and it's going to come easy for you. I'm also psychodynamically trained, so I came to CPT as a psychodynamically trained clinician. It was really hard for me to listen to thoughts and figure out how to use worksheets. And so I really learned CBT through cognitive processing therapy. So there are many clinicians who are well-versed in it and then learn cognitive processing therapy, or like me, who come from other modalities and are learning CBT while they're learning cognitive processing therapy. Did that answer it? But it's a specific intervention for PTSD, and we sort of do specific PTSD interventions that just gives it a little flavor than, you know, in the same way CBT for depression or CBT for anxiety might be different.
Got it. Yeah, no, I think, and I welcome the person who submitted that question, and if they want additional follow-up, please follow up with additional comments. We also had a question around differences between CPT for people with complex versus single episodes of trauma. Yeah, that's such a great question. I get that, hear that a lot. And so, you know, even for folks who are multi-traumatized, we're still going to look for the event that's most driving the symptoms. And sometimes that is pretty easy. And clients are able to really say, no, that all these 10 events are terrible, but this one really stands out as the most distressing and causing the most symptoms. Sometimes it takes some work between the client and the therapist to figure out where to start. So with someone with a complex trauma history, that's where we'd start, trying to figure out which event might be the one to start with. So folks with complex PTSD, the way, and Dr. Rizik was on one of these papers, I don't have it off the top of my head, but I believe it was 2016, that was really looking about how should we conceptualize CPTSD. It's not in our DSM, right? So how do we conceptualize? So here's how we think about it in CPT, and here's how I think about it, is that complex PTSD is when there's PTSD, but there's also a lot of other comorbid conditions. There might be an eating disorder, there might be borderline traits, there might be substance abuse, there might be attachment disorders, right? And so what we want to conceptualize is, by targeting the PTSD first, does that try to help get at those other things, or do we need to stabilize some of these other comorbidities first before going after the PTSD? So that's how we conceptualize it. And CPT absolutely can work.
but they've got to
Right.
be motivated. We've got to find that index event, and PTSD needs to be the primary diagnosis. Hope
Great.
that
I think we
answers
have
that question.
Thank you. I think we have 2 more questions before we kind of have to wrap up. And one came in a little earlier around the age of 14 and whether the age of 14 is considered a minimum age, and is that cognitive or temporal age? Or,
Oh,
you
well,
know, sort of taking into account development.
Yeah, that's really interesting. Well, so, you know, it'd be interesting to have the folks who did that adolescent study comment more. But I think if you're going to think about using it with a younger adolescent, right, we want to understand that there's at least enough cognitive development where they can abstract what's a thought and what's a feeling and put that on the worksheet, right? And so there might be some 14-year-olds where you know, maybe we want to try TF-CBT with first. But there might be 14-year-olds who really kind of get it, and you know, they don't want to have an adult in the session with them for TF-CBT. And so cognitive processing therapy might be a really great intervention to also offer for them so they can choose. I've had some folks in consultation try it with 12 and 13-year-olds, and it didn't seem to go as well. So I think it really, as with anything, it needs to be a case-by-case decision where you're really talking through the client, and the case with a minor where you might need to be talking with the guardians or the parents to figure out what the best treatment is and kind of weighing the pros and cons of that.
Great. And so we have a quick follow-up, so maybe we can get a brief response to the original CBT versus CPT question. And the reply was CBT, cognitive behavioral therapy, is not necessarily a directive style.
Yes.
Can you elaborate?
Yes. Yeah, and I guess it depends on what kind of CBT or if you're doing a protocol or not. And so that's a very important clarifying. So in a protocol, we have to be more directive, and especially with post-traumatic stress disorder, because avoidance is so prevalent, we have to be collaborative but directive. And we're also deriving the agenda. So if someone comes in with a crisis at session 4, we want to obviously tend to that crisis. So here's an example. We want to tend to that crisis and have empathy, but we also don't want to collude with avoidance and shortchange the trauma work. So how do we work collaboratively with our client to tend to what they're bringing and then gently bridge to the trauma work, and so we don't shortchange that? And so that's what I mean by directive.
Great. Thank you so much, Wendy, and thank you so much for such an informative webinar. And I'm just going to go through 1 or 2 more slides around accessing CEs and contact emails as well as we wrap up. So as you know, for those of you who are interested in getting a CE as social workers or licensed mental health counselors, you can, for attending this webinar, you can get 1 CE. And so here are some directions. I know it's a lot to cover, so we're going to follow up with an email with a link to where you can access and register for the CE. So the CE is delivered through the NYU Silver School of Social Work, who is our collaborator and partner. And you can either go directly to their CE portal, Continuing Education Online portal at their website, or this direct link. Again, we'll email that to you separately. You'll need to either log in if you already have an account, or register, create accounts, and there is a $25 CE registration fee. And then there'll be a process in which you'll receive a confirmation email, and we'll need to complete an evaluation. And with about a day or 2 of that time, you'll have a certificate. And any questions or concerns that you have, you can reach the NYU Silver School directly, either at this phone number, 212-998-5973, or through their email, silver.continuingeducation@nyu.edu. But again, I know that's a lot of information to cover, so we'll follow up with a thank you email for attending the webinar and have the link to the website as well. As a reminder, today's webinar recording and the slides will also be posted on the ctechny.org website, so you'll be able to refer to it, share it with your colleagues, and revisit the information again, especially if you didn't get a chance to capture all of it. This is Wendy's contact information, Wendy Bassett, lcsw@gmail.com. Feel free to reach out to her about any questions around this presentation. Also, if you're interested in additional training around CPT, I'm sure she'd be happy to point you in the right direction or get you connected with the NYU CPT training program. For CTAC-specific questions, please feel free to email us at ctac.info@nyu.edu or access our website, again, at ctacny.org. And as you close out of this webinar, there will be a feedback survey that will pop up, and we ask you to please take a couple seconds to answer that survey, as we do read your feedback and incorporate it into our future offerings. Thank you, everybody, for participating today, and thank you so much, Wendy, for such an informative presentation. Great. Thank you, and have a great rest of the day. Take care.
Thank you. Bye.